to come in Bob and Brad, the two most famous physical therapists on the internet.
Hello, everyone. I am live with Rick Olderman, physical therapist today. Rick, I didn't know if you were expecting that song to pop in there, but it made me chuckle at least.
I was not. It did make me chuckle.
We are taking anyone's questions today about pain relating to physical therapy, at least, and we will do our best to answer you. We will be live from 10 a.m. to 11 a.m. Central Time. So feel free to pop your questions in the chat, whether you're on Facebook or YouTube. Before we get started, Rick, do you want to tell people a little bit about your background?
I'm an orthopedic physical therapist for going on 30 years, and I've written 9 books, and I've, owned my own clinic for almost 10 years. So yeah, that's about me.
I'm going to answer some of the questions, but I'll probably let Rick take a brunt of them because I am trying to go through all these questions already popping in. So I'm going to be reading and putting stuff on screen and giving advice when I can. So we already got a handful of questions started. So are you ready to go, Rick?
I am ready.
All right. So our first one comes from Vicky. She says, "Good morning. I'd welcome advice on controlling neuropathy pain."
So I think, first of all, Vicky, so neuropathy pain is kind of a very broad term. So that includes radiculopathy, which is, like carpal tunnel syndrome or nerve pain down your arm or down your legs. I'm not sure whether this is in your feet or in your hands or where this is. But most neuropathy pain that I treat, I see the body as a system. And so we look at the source of where this neuropathy pain likely is coming from. And if it's in your upper body, like in your hands or something like that, then likely the source is coming from a shoulder blade issue that is then stressing the neck, causing compression of the nerve roots running down your arm. And if it's in your legs, then typically the pelvis and lower body system is stressing the low back, which is then causing compression of the nerves, causing radiculopathy down your legs. So I'm not sure if this is bilateral symptoms, whether it's both feet or both hands at the same time, or whether it's a unilateral. So if it's a unilateral, in my opinion, this speaks to a likely biomechanical cause of this pain, like what I just described. If it's bilateral, meaning in both hands and it's happened at the same time in both, then likely this is more of a central issue coming from your spine, like a disc issue or something like that. So without more information, it's hard to answer that one.
Sure. Vicky, if you're still watching, you can comment more if you'd like. I'm going through them, but until then, I'll go to another question. So Judy says, "I had a knee replacement on May 8th, 2025, so a few months ago. Still using a walker some of the time. What is a good way to transition from walker to a cane?" So Judy, oftentimes it depends on what your walking pattern is like and how much pain you're still having. If you're still limping a lot or you have a limited range of motion in your knee yet, so you can't bend it enough or can't straighten it enough, then maybe a walker is still a good idea. Otherwise, a cane, if you're walking normally, with a cane is fine. It's just if you go too soon, you'll notice because you'll be more sore or maybe you'll feel less steady. I'm not sure if you have balance issues as well. So it's kind of a personal matter of when you transition. There's not like a hard timeline. And a lot of it depends too. If you're using a walker before surgery too, it might take longer to get to a cane. If you aren't using anything, then just transition when you feel safe. And as long as your walking mechanics seem somewhat normal, it should be fine. You have anything to add?
Yeah. So, I mean, May is still relatively recent. So I'm curious. This seems to be something that I'm hoping, Judy, that you're seeing a physical therapist for your rehab for this. So, and they should be guiding you. And if you want to transition to a cane, please talk to your therapist to let them know so that they can be more aggressive with your rehab. Now, specifically, moving from a walker to a cane, what I have done in the past is typically I'll have someone just, we'll be in the clinic and they'll have their walker. I'll give them a cane and we'll put the walker aside, and then I'll just simply have them practice stepping forward and stepping back with that, holding onto that cane to start practicing. And if that feels secure, then we go a little bit slower. So then you have to balance a little bit more going forward and back while you're doing that. And if that feels safe, then you can start taking a second step with that cane. So it's as simple as that. But some of the things that might, like what Mike was talking about, if you're in a significant pain still, that could slow this down for you. So what I have found, Mike, one of the reasons that people are in a lot of pain, or if they haven't had a lot of range of motion, is usually because this little muscle that we've talked about occasionally, the popliteus on the back of the knee, is in spasm, especially after a surgery or traumatic injury of some sort. There's a little muscle that runs from the lower tibia up to the upper outer fibula. And so because it's crossing the knee joint like this, it causes the knee joint to be rotated. And I have had seen significant pain reduction and increase in range of motion by simply massaging that popliteus muscle. So if you're in a lot of pain, Judy, I would say, why don't you ask your therapist to massage that popliteus muscle? And I can almost guarantee you're going to gain instant range of motion in your knee. But also it'll be significant pain reduction, which may then allow you to start transitioning to that cane without so much pain. And then the last thing I would like to mention is the tighter that your calf and soleus muscles are in the lower leg system, the more that they will cause your knee to lock backwards and be straight. And so if you haven't been doing any ankle range of motion or calf or soleus stretching, I would also do that, because that prepares you for going upstairs and downstairs and going up and down off of curbs and uneven surfaces and so forth. Your ankle needs to be able to bend, like this in order for your knee to work. And so if you have previous issues with your ankles or you have a lot of tightness there, I would have your therapist address the tightness that you have in that system as well as the knee. And that could actually free up the knee to do what it's supposed to do as well.
Yeah, actually, I have a patient right now that's had a knee replacement, and she's like 6 to 8 degrees from full extension for a while now, and she has some tightness, and I just assumed it was hamstrings. And then I asked her, like, where is it? She's like, no, it's in my calf. And I mean, she does have some edema as well, which is limiting it. But yeah, I just kind of massaged her calf a bunch the other day and just kind of like tried to get it to go down that way too.
Yeah,
so,
Mike, I would try that popliteus release. It is magical. It really is.
I could hear you well, but I think it's picking up your mic on your laptop and not your headphones. So if you want to check that. I just noticed when you stepped away, I was like, oh, he's quieter now.
That's odd. It's showing that it's picking up my headphones. So I'm just going to turn them off and just go with the mic on the computer. How's that?
Well, yeah, I mean, that's what I've been hearing the whole time. I haven't been hearing your headphones.
All right.
I mean, I can hear you. It's just not quite as, when you move away, it's not as loud. That's all I know.
Yeah. Okay. Thanks for letting me know.
Can you hear me okay yet?
Yeah, I can hear you.
Oh, okay.
I'm old, but not that old, Mike.
Just want to make sure the audio isn't only through your headphones. Well, Denise says I have a trapped nerve, but she didn't tell us much else than that, so I don't really know how to answer that one.
Yeah, so Denise, a trapped nerve, so there's any number of places a nerve can become entrapped, and often in medicine we'll blame a radiculopathy or neuropathy issue on a trapped nerve, but it may not actually be trapped. It may just be stressed because of the biomechanics of your system. So that, when I hear something like a trapped nerve, that's focusing on just a very small area of your body. And, because I help people by fixing systems, I would look at the entire system. Again, if it's an upper body trapped nerve, then I would start at the scapula, looking at how that's supposed to function. And if it's a lower body trapped nerve, then I would be looking at your lower body system and pelvis to understand this better.
Our next question comes from Lisa. I have pain in my hip when I wake up every morning. What can I do to stop it? Well, Lisa, do you have pain at any other time of day, or is it just mornings? Because that'll help us understand if it's like some type of chronic issue or just when you get out of bed, are you sleeping really weird and getting in an awkward position, I guess. Do you have any tips otherwise?
Yeah. So, I would also wonder where in the hip it is. In the back of the hip, the side of the hip, the front of the hip. Is it, all of these kind of tell us a little bit more about what's going on. But in general, what I have found that is causing most hip pain is something called an anterior femoral glide syndrome, where the femur head is sliding forward in the hip socket uncontrollably because of poor butt muscle function. So what I would be interested in, what was her name, Lisa? Mike?
Yep. Yeah.
Okay. What I would be interested in, Lisa, I recommend that if you can get on your hands and knees and do a butt pump for 2 sets to fatigue for that glute before you go to bed, that helps pull the femur head back in proper position in the hip socket. And I would be interested if you woke up the next morning with less or no pain as a result of that. If that worked, then you likely have an anterior femoral glide syndrome. Why would the butt muscle not be working? Usually it's around how you're walking. And more specifically, when people walk by locking their knees, that turns off the butt muscle. And therefore, we start getting sloppiness in the hip socket, causing all sorts of types of hip pain.
Yeah, I still have some lingering hip issues periodically, but they're way better than they were. But oftentimes, if I have them in the morning or any time of day, I just do some glute pumps with a band, and then I'll do some other like clamshell type things too, just to get my glutes firing. And then normally I'm fine for the rest of the day. So it's good just to get them, I don't know, firing up again, I guess is what I say.
Yeah. And I also wonder if she's doing a lot of sitting during the day, then if you do have an anterior femoral glide syndrome, when the hip is flexed, that's when it starts moving out of position the most. So that's when it starts migrating forward in the hip socket. So, if you periodically get up and walk around, especially with the idea that I'm not going to lock my knees when I'm walking around, that helps turn on the glute throughout the day. And therefore, it'll be in a better position when you go to bed. So that might be another thing to think about.
Emily says, I'm sitting with an ice wrap on my knee, pes anserine, and Baker's cysts. No more information than that. Do you have anything to add for that?
Well, this goes back to my first, without any more information. So, what we talked about with the woman with the knee replacement. So again, a pes anserine and a Baker's cyst, those are specific tissue diagnoses, but we have to understand why those things are irritated. And in the first place, there are many, and we could spend a whole hour talking about just this, but there are many reasons why that could be. But what I would recommend, Emily, is that you look up the popliteus, muscle. Ask your therapist. I hope you're seeing a therapist. Ask your therapist to massage the popliteus muscle for you. And I can almost guarantee that pes anserine and even the Baker's cyst pain will likely decrease as a result. And then again, I would look at, like I mentioned earlier, your ankle range of motion, whether your calf and soleus muscles are limp and your ankle is moving well enough, because that will stress the knee joint. And then in our last question that we just talked about with the hip pain, it could be coming from the hip because the butt muscle is the primary controller of the thigh bone. And so if the thigh bone is not controlled well, the thigh bone comprises half of the knee joint. So if you have butt muscle weakness, this could cause uncontrolled rotation at the knee joint. And so this could also be the cause of stress to these tissues.
She did comment again that she actually has some osteoarthritis and got some injections for it as well.
Osteoarthritis in the knee?
Yeah.
Okay. So it doesn't matter whether you have osteoarthritis in the knee in terms of all of these biomechanical issues. So an osteoarthritis diagnosis is a structural diagnosis, meaning that you have a structural change in the surface of your cartilage in your knee. So it makes it even more important to remove all of these stresses acting on that cartilage breakdown. And all of the things that we just talked about, ankle range of motion, popliteus muscle, walking with your knees locked, turning off your glutes, all of those cause stress to occur at the knee joint that then break down the cartilage in the first place. So to me, I would be looking at your gait pattern, whether you have an anterior femoral glide syndrome, whether your butt is turning on when you're walking, you have good ankle range of motion, all of those things.
I will mention, if a lot of this sounds very foreign to you, which it did when I first met Rick, you can go to his website at rickolderman.com, and he has programs with all this in details on there, and books as well. So you can educate yourself on it and learn a lot.
Yeah, I also have a YouTube channel that, has a lot of videos too that you could watch that will help you understand what I'm talking about.
Yeah, it's Rick Olderman is Olderman for those curious.
And Mike, I just want to mention, the reason this may sound confusing and like a foreign language to you is because medical practitioners are not trained to understand the body from a system standpoint. And so most practitioners will always be focused on the tissue that is painful, but not why the tissue is painful. And so what Mike and I are talking about today are reasons why the tissues are breaking down, not so much identifying a specific tissue that's broken down. By that time that it's broken down, it's not too late for the tissue, but we need to understand and fix the reasons why those hammers are happening on your body.
Our next question comes from Elaine. Good morning. Thinking about, I don't know what radio pressure waves are, for IT band or bone calcifications in hip and knee. I'm not sure what that treatment exactly is, but I can tell you that usually if you have IT band syndrome, hip and knee pain, that the IT band runs from the lateral hip to the knee. For those of you that don't know what it is, it's a very thick tendon fascia region that runs, where Rick is showing there. And oftentimes, if it's on one side, you have some sort of dysfunction. I could say just not locking your knees, personally, for me, helped a lot, whether it's standing or walking, because I do have a tight IT band on one of my sides. I also do a lot of distance running, which was part of it, but fixing my form with walking, standing, and running has greatly reduced that. Do you want to talk about like bent knees with stuff, Rick?
Yeah, so I have no idea what radio pressure waves are.
I
So
don't either.
this is a unilateral.
It didn't specify, but
Okay.
I presume.
Yes. So again, all of the things, it's interesting. All of these questions are centered around the lower body system, right? And so the way that we're supposed to be, walking, when we walk, most people, when they walk, they advance their foot in front of them and then their body comes over. And when this happens, the knee tends to lock, the butt then turns off. And so we have no control over the pelvis, lumbar system, hip, knee, and even foot, because the gluteal muscle is the one muscle that controls the whole system from the low back all the way down to the foot. So typically most problems that I see involving, knee, ankle, hip, back, whatever, SI joint, doesn't matter, sciatica, it always goes back to a gait pattern. And what Mike was just talking about is that even with an injury that he's experiencing with running, he's fixing his walking pattern, because he's walking so much more during the day than he is running during the day. Most running injuries are a result of poor walking patterns, just like all of these issues that people are talking about. An IT band friction syndrome that what this woman is talking about could actually be an anterior femoral glide syndrome, because if the femur head is not in the correct position in the hip joint, and the femur head is running underneath that IT band that runs down to the knee, then it's going to rub excessively and cause tightness on the IT band, diagnosed as an IT band syndrome issue, or it could be diagnosed as a bursitis issue as well. So again, I agree with you, Mike. This goes back to walking correctly, which means that your body is advancing with the foot instead of your foot advancing without your body. And then making sure that the gluteal muscles are turned on, which is controlling that whole system.
Yeah, because oftentimes if people get some treatment like whatever radio pressure waves is, it can help temporarily, but you're not fixing the origins of your problem. So
okay, can I speak to that? And just this is going to be a little rant.
Okay.
All right. So what this sounds like to me, and a lot of physical therapy is going, and other medical practices seem to be going to treatments as opposed to solving problems. And this is because treatments can be our modalities like ultrasound, radio pressure waves, e-stim, hot packs, cold packs. That's what I'm talking about in terms of treatments. These have specific diagnosis codes for insurance companies. And so physical therapy is trying to often put in 2 or 3 different types of treatments so that they can bill to insurance companies for reimbursement. The treatment, though, that isn't focused on solving the actual problem. It's about reimbursement. And it's not that the therapists aren't caring about solving the actual problem, but the therapists also need to get paid. And so this is what I feel, this is one of the reasons why I sold my clinic 3 years ago, is because I was being more and more pressured to do treatments as opposed to solving problems. And I just couldn't go down that road anymore. And so I sold my clinic and let someone else deal with that. So that's just my little rant about what I think is going on with a lot of, a lot of treatments, not necessarily radio pressure waves may be a miracle. Who knows? But, think about, is your treatment solving the problem, or is it just, decreasing your pain?
Next question. For those of you wondering, I'm reading questions over here. I'm not spacing out. Tracy says, good day, pain under medial scapula radiating up through rhomboids and scalenes towards the jaw and outwards to right hand intercostal area. Any cause and treatment recommendations? For those of you who are wondering, she's kind of talking about her shoulder blade, and then it's going up into her jaw area and into her ribs a bit. Yeah, what Rick's showing right now.
And then down her arm. Is that right, Mike? It's also going
down. Yeah, it sounds like right. Yeah, into hand.
Yeah.
It says right hand.
Well, this is exactly what I talked about in the very first question, that with the woman who was talking about her neuropathy. So this woman is describing exactly what I was just explaining, is that I'm going to bet that her pain began in the scapula and then migrated eventually up to the jaw and down the arm. And usually, so the scapula, the reason I say this is if you look at the architecture of that scapula, you can see it's a broad, flat bone. All right. We only have one other place in the body that has a broad, flat bone, and that's the pelvis. All right. We all know that the pelvis is the center of function for the lower body and low back system. Likewise, the scapula is the center of function for the upper body and neck and head system. And so problems here then migrate up into the head, causing chronic headaches like migraines, tension headaches, and so forth, and or radiculopathy heading down the arm. So when I'm listening to this person's description of her pain, it sounds like and there are rules about how the scapula should be moving. One of them is that the scapula should be resting approximately 3 inches from the center of the spine here. All right. This border of the scapula should be resting 3 inches from the spine here. And so what is often happening is that people are using their shoulder blades, pinching them together to create posture. Often, especially if this person has been involved with dance, gymnastics, a lot of yoga or Pilates, the cueing is to bring the shoulder blades down and back into the opposite back pockets to create this aesthetically pleasing long neck. This is dysfunctional mechanics, though, for the scapula. And so what happens with chronic engagement of this pinching behavior is that you do get this burning in the scapula and rhomboid region because these muscles are constantly working because you've trained yourself to fix your posture by squeezing the shoulder blades instead of using your core muscles. And then there are muscles that attach from the shoulder blade up into the neck and the base of the skull that then cause chronic neck and headache issues and now jaw pain for this person and radiculopathy. So the source likely is her posture strategy and the fact that her scapula is likely locked into this posture strategy on her rib cage. And so my inclination would be to first assess the landmarks of the shoulder blade, and we can talk about those if you want to. But then we need to loosen the scapula away from the rib cage to let it move freely. Now, one exercise that would be really easy, I would be really curious about, is if she got on her elbows and knees and just sat back on her knees and on her hands and knees, and her hands are on the floor here, and she sits back on her knees, which essentially pulls the arms up overhead. I bet she's going to feel a big stretch through the scapula area. I would be curious if she just simply did this stretch for a minute or two, whether her symptoms would reduce. And if so, then this is confirmation that it's a scapula issue and not so much a specific tissue issue.
We have a lot of shoulder questions back to back here. So I'll just go into those and I'm sure your answers will get similar. So the next one was from BF. Good morning. I would be glad for any advice regarding bursitis and tendinitis in my arm. I've had it for 6 months now.
So where is the bursitis? Maybe that would be helpful.
Yeah. Is it more shoulder
or tendinitis?
elbow?
Is it an elbow? Is it a wrist? Is it a shoulder?
Yeah. BF, if you're still watching and want to comment, I'll look for your comment.
All right. So, well, regardless. All right. So if this is a shoulder, please refer to the previous question, that answer, because that's what I would probably do is assess. It's likely a scapula issue. So why would we have a bursitis in the shoulder? It's because the arm bone is moving against an unmoving scapula, typically, that then irritates the tissue. It causes itis.
It's in the shoulder.
Shoulder. Okay. So itis, folks, simply means inflammation. It means that something's rubbing on a bursa, causing it to be inflamed. The bursa is a lubricating sac.
Tendinitis in arm, bursitis in shoulder.
Yeah, tendinitis, and by arm, I'm guessing he means elbow. So a bursa is a lubricating sac, and so if that is getting irritated, it just means that there is excessive work happening on those tissues. Well, if you're raising your arm up overhead and your scapula isn't helping, and look how big this thing is, and there are massive muscles attached to this thing, it's supposed to elevate and upwardly rotate to help the arm lift. If that's not happening, then you're relying on these small shoulder muscles to do most of the work, and the bursa is right there. And so the bursa starts to get irritated because of all the work these smaller shoulder muscles are doing, rather than the big scapula and the scapular muscles doing the work. So again, what I would start doing is that all fours rocking exercise that I just mentioned last time. And I would do it periodically throughout the day to see if this starts to relieve your bursitis pain. Because when you rock back on you're on your hands and knees and you rock back, what that's doing is it's pulling the scapula up into a position that it's supposed to be in when your arms are overhead. So it's helping you achieve the landmarks that we're supposed to have that you're not doing on your own, without that. So this would be a nice way. It'll stretch the tissues that are disrupting the scapula, and it'll start to train the scapula to move the way it's supposed to. And if that's helpful, then you can start doing it up against a wall or a door or something, and just really reach up as high as you feel the scapula elevating rather than just the arm elevating. So that getting the scapula involved will unload the bursa. Now, the second question that he has about this tendonitis, most elbow tendonitis, like tennis elbow, golfer's elbow, I'm treating someone with de Quervain's tendonitis, which is in the wrist. Most of these things are due to, and I'll tilt my camera down a little bit.
They did say they're playing too much pickleball.
Yeah. So, but regardless, most of these things are due to tight forearm pronator and supinator muscles. So these muscles rotate the forearm. And most people, because we're typing all day or on our gadgets and so forth like this all the day, what happens is our supinator. So our supinator muscles become tight. And so an easy test is to simply be in front of a mirror, start with your thumbs up like this, just rotate your palms to the ceiling. Can you rotate them 90 degrees? And if you can rotate them 90 degrees, do your elbows then have to press into your sides in order for them to rotate to 90 degrees? If so, because they should be able to rotate freely without your elbows moving at all. And then if that's the case, if your elbows have moved, that means that your supinators are tight. And then you go back to neutral, and then you do it to the other direction. Do your elbows have to move away from your body in order to rotate your palms down? This means that your deeper supinator and pronator muscles are too tight, which then stresses the whole, and they insert right where we have golfer's elbow and right where we have tennis elbow pain. And in terms of this guy with de Quervain's, we reduced his de Quervain's syndrome pain, which are tendonitis in these thumb tendons here. We decreased that by 75% in 3 minutes simply by stretching his forearm pronators and supinators. So the deep forearm pronators and supinators are huge with elbow and wrist symptom tendonitis.
I'll just mention,
and I'll be making a YouTube video about that one at some point.
Yeah, go follow Rick's channel too. He's got lots of good information. I'll just acknowledge this person that had a comment about shoulder pain one side, very flat back apparently. Can this be fixed? I think you guys are amazing. A lot of the stuff Rick just kind of mentioned would work for this, Coleman. So you can give those a try. Is there anything else you want to add? Otherwise, you can rewind the live, by the way, anyone watching on Facebook or YouTube, to replay what we just showed. So,
yeah, I think I just want to talk about his comment about flat back.
Sure.
So what I have found is when us medical people can't help a patient, we start blaming it on something the patient can't possibly change. All right. And in this case, if someone has said, oh, you're having your shoulder pain because your back is flat, well, you can't change a flat back. And therefore, it absolves the medical professional from actually solving the problem. Well, you've had a flat back likely all your life, and the shoulder pain has been relatively recent. So it couldn't have been completely due to the flat back. So while the flat back does influence how the scapula move, likely it's a scapular issue, like what we've described here. So this is the third time that we've talked about the scapula. So I'm going to now go into the landmarks that the scapula should be achieving so that people understand what I'm talking about. Okay, and I'll go through this really quickly, folks. I won't bore you. But when the arms are down by your side at rest, the shoulder blade should be resting at thoracic level 2. And this border of the shoulder blade, the medial border, should be resting 3 inches from the spine, whether you're 7 feet tall or 5 feet tall. And then if the resting landmarks are off, then likely your overhead moving landmarks are going to be off. When the arm moves, when it gets to about 60 degrees, the scapula is supposed to start upwardly rotating and elevating to help push the arm up overhead. All right. The upward rotation should be approximately 60 degrees. And the elevation, this acromion should reach approximately cervical level 7. And then this little corner of the shoulder blade right here should be coming to the midpoint of the rib cage. And almost everyone I've seen with chronic neck, headache, shoulder, elbow, carpal tunnel syndrome, and so forth, they don't even come close to these landmarks. And so when we restore the landmarks, it restores the system operation. And all of these tissues are then unloaded because everything's working as it should. How do I begin getting these landmarks restored? Well, first of all, I measure them to make sure to understand which ones are off and why. But like I've told you all a couple times, this all fours rocking stretch where you're on your hands and knees and just sit back on your heels, this goes a great distance to fixing the scapular landmarks, because the hands are then, because they're anchored on the floor, they are then pulling the scapula up where they should be going already. And it's stretching the tissues that are keeping them from achieving the landmarks that they're supposed to be making. So this is a great place to begin. And this is a good place to talk about test-retest strategy. So let's say you have shoulder pain and it hurts every time you raise your arm. Oh, there's my pain right there. Ouch, 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 ouch. And then it's not hurting at the very top, okay? So you want to know where your pain is in your range of motion first, and get a sense of the degree of pain. Is it a 5 out of 10? Is it a 7 out of 10? And note specifically which range of motion you feel that in. Then you do the all fours rocking stretch hold it for a minute or so, twice, all right? And you stand back up and you raise your arm up again. Oh, well, now I can raise my arm here, and now I have maybe a 2 out of 10 pain. Not that 5 or 7 out of 10 pain I had here. This is called a test-retest strategy to tell you whether you're on the right track of solving your pain or not. You can do this for anywhere in the body, and use any exercise that anyone has ever given you, that they think is going to solve your pain. You can actually test it like this to see whether it actually solves your pain. And so this is a way that I do with all of my patients. I have them start, and we do, like with a shoulder issue, we'll do the all fours rocking stretch. Okay, now retest. Oh yeah, my pain's decreased by 25%. Or I can now go all the way up with a 3 out of 10 pain instead of that 5 or 7 out of 10 pain. So this tells you that you're on the right track. And this is how you can test any and every exercise, whether it comes from me or any other practitioner, to solve your pain. Answer. Sorry.
That's okay.
I had to get it out.
We have a lot of questions here, but they're all somewhat. I'm going to get off shoulder for a little bit because there's a lot of shoulder ones, and we kind of just answered a bunch of them.
Okay, so can I speak to that, Mike?
Sure.
If there are a lot of shoulder questions out there, it means it's because your therapist or whatever are likely not treating you from a systems standpoint. They're treating you by isolating tissues and, okay, I'm going to strengthen my rotator cuff. But that rotator cuff strengthening is not doing anything to restore scapular mechanics. And so this is why we have a ton of shoulder and neck and low back problems, is because these are the 3 areas where I feel, in physical therapy anyway, our training doesn't teach this type of systems understanding. And so we have chronic issues that are frustrating people out there because of it.
This one's kind of similar to shoulder still.
I'll get off my soapbox now.
Sheila says, can poor posture cause rib pain? And what are some good exercises to improve posture? Yes, poor posture can cause rib pain because if you're flexed over forward, you're compressing your ribs more and you're putting more stress on your... I don't know if your rib pain's in front or back either, but this can cause a lot of shoulder, rib, headaches, back pain, having any form of poor posture for prolonged periods of time. What do you want to add?
Well, let's go ahead and teach them how to achieve proper posture using the right muscles. How's that?
Sure.
All right. So this is something called lifting the rib cage. So like I mentioned earlier, many of us, if we've done a lot of yoga, Pilates, dance, gymnastics, or watched just videos on YouTube, everyone's saying to squeeze your shoulder blades back in order to create good posture, right? And this nice, long, aesthetic looking neck. But that's the shoulder blades. If you look at the system, the shoulder blades are outside of the core system and the ribcage system. They're not designed to create posture. They can assist, but they shouldn't be the primary go-to for your posture strategy. And this is why we end up having a lot of chronic shoulder, neck, and headache problems, is because of this faulty training. While aesthetically pleasing, it's not functional. So a better way is if everyone stands up right now and they put one hand on their upper chest and one hand on their belly. And if you take a deep breath, you'll feel your rib cage elevate. And then when you exhale, you'll feel the rib cage go down. Go ahead and take another deep breath and feel that. Okay, so now that you've confirmed that this is happening with your rib cage, go ahead and take another deep breath. And then you're going to exhale all the way just as before, but you're not going to let the rib cage come down all the way. It can come down 99% of the way, but don't let it come down that last 1%. And when you don't allow the rib cage to completely collapse again, you'll notice that your stomach muscles have just engaged a little bit. This is your core, and this is why we have 4 layers of massive core muscles to hold up the whole rib cage and upper body system. So now your core has just engaged ever so slightly to hold this up. Now notice I didn't ask you to contract your core muscles. That is faulty patterning. So really, if you just hold your rib cage up a slight bit, just a little bit, the core will engage as much as necessary to maintain that position. You don't have to have this 100% contraction going on. You don't need to do 1,000 sit-ups to achieve this. Simply just hold up the rib cage a little bit, and that is your core. That's all the core strengthening that you need, and it will activate all 4 layers of your core. Now, the second part of this equation is then to bring your arms down by your sides and roll them around and make them like 2 loose ropes dangling by your sides. And when you do that, when you completely relax your shoulders and arms, you will notice that you've just also lost your core activation. The reason is because you've tied posture to shoulder strategies instead of core strategies. And so this is how you change your posture strategy correctly and retraining the proper muscles to hold you up, namely your core, but ever so gently. Just hold the rib cage up a little bit and then relax your arms, take them out of the equation, and your core will activate just as much as necessary to hold this up. Again, I'm not telling you to contract your core. I'm asking you to elevate your rib cage just slightly, enough to activate a little bit of the core activation. It should be like 5% or 10% of your maximum core muscle contraction.
We just had someone comment they were doing it with you and it felt really good. And then someone else subscribed to your channel because they like you now.
All right.
Next question is from Sandy. My dear friend had to have her knee replaced a second time due to infection, which has left her in a lot of pain. She feels there is nothing that can be done, which may be true, ? I would say it's probably frustrating because she already went through it once and had to do it again, and total knees are painful. But as long as this one stays clean and she works on her range of motion, especially in the early phase, most knee replacements go really well as long as you keep working on that motion and obviously the infection doesn't come back. But I would tell her, Sandy, not to get discouraged. It's just takes time, and I realize it's frustrating, but it's better than giving up on it because then she'll really be reluctant about it later. So do you have anything to add?
Well, I would also, I'm curious, at what point did the infection happen? Did it happen immediately after the surgery, or did it happen further on down into rehab? And so I would be curious about how was her rehab going prior to the infection occurring? And if it was going well, then she can expect that this next one will also go well. The infection has nothing to do with the function of the knee other than having an infected tissues, right?
Yeah.
So, she needs to separate this idea of oh, I'm broken because I was infected and needed a second knee replacement. That has nothing to do with what your muscles and bones and mechanics are capable of doing. That's completely separate. So if the infection is solved, now it's time to go down the road of mechanics and fix the knee replacement and do the rehab. The infection has no bearing on your success with your rehab. So hopefully that gives her hope that, she can emerge from this better than ever.
We have a lot of questions. I'm going to kind of skip around a little bit just because there's so many and I'm trying to get different topics. Lisa says, what can be done about spine bowing at the top of my back and causing pain going into both shoulder blades? Rick kind of talked about this with the lifting the rib cage with breathing. Obviously, looking at your posture throughout the day in different positions, whether standing, sitting, laying down, is important because you're in those positions for prolonged periods of time. So if you're sitting with a poor forward rounded posture for many hours a day, you're going to get stuck in this pattern. So working on extension different times throughout the day can be beneficial, whether that's standing up, laying down on your back. I'm not sure if you can comfortably do that, but oftentimes just going in the opposite direction to stretch out the muscles can help. I know you like snow angels, Rick. I don't know if you want to talk about those or any other ideas.
Well, I'm curious about the description of bowing. Do you think that means kyphosis, Mike?
That's what I was imagining. So
Okay.
People don't know we're talking about like forward rounded posture like this.
Yeah. So if someone has excessive rounding of the thoracic spine, this is called kyphosis. And what this may be what Lisa's talking about in terms of bowing. And so what happens with people with a lot of kyphosis, I've talked a lot about the shoulder blades. What happens is that these people tend to then squeeze the shoulder blades even more to offset the rounding that Mike's describing, right? And so we get a chronic irritation of these muscles of squeezing the shoulder blades together to try to compensate for the kyphosis. So I would be curious whether Lisa is doing that. If she thinks she's doing that, I would have her do the all fours rocking stretches like that seems to be our sponsor for today, right, Mike? Is the all fours rocking stretch.
Yeah.
So anyway, I would have her do the all fours rocking stretch and see if that alleviates any of this burning or whatever pain she's having between her shoulder blades. And if so, I would ask her then to try. So this is a tough one because when people have this kyphosis, they believe it's not aesthetically pleasing. And so they don't like to be rounded like this. And so they're spending so much time trying to straighten up and offset that kyphosis that it causes this burning sensation between the shoulder blades. So I would encourage her to try that lifting the rib cage strategy instead, but try not to lift the rib cage excessively because she's going to want to come way up to offset this kyphosis, but try not to fall into that trap. We're not going to change that kyphosis of the spine. You have to become comfortable with, should I be this tall or can I be this tall or can I be this tall? And does it really look so bad if I'm here versus here? So that would be, and if you can be good with being here instead of here, then I bet you a lot of the scapular pain will go away because then you will start to relax your shoulders to allow you to be here rather than here. And so this gets into a lot of the idea, the idealized version of how we think our posture should be. This woman, Lisa, will probably need to really investigate how she thinks about posture and how she thinks about what she looks like in order to stop this overuse of the shoulders and over recruitment of all these back muscles to try and offset the kyphosis. Another thing that you can think about, Lisa, is they have these posture braces on Amazon. And if you wear that, what they will do is they will pull the shoulder blades back for you. And if you really feel like you need to be up tall, then let's get a posture brace from Amazon that pulls the shoulder blades back for you. And that way that will allow these muscles to turn off. And that burning and pain should go away at that point then. So that would be my other recommendation.
I'm gonna kind of skip around a little bit to a question that came in recently. Hi from Laney. What could be causing pain in the muscles in my groin area? Thanks. First off, make sure it's your muscles, because sometimes if you have hip issues, it actually, you feel it in your groin. But other than that, if it's musculature, it could be your adductor muscles. It could be your hip flexor. I'm not sure what area of the groin. I always think adductors, but do you have any ideas here?
This is another one I could talk about for an hour. But so, if you remember, Leslie, hopefully you've been on this call the whole time, and you've heard me talk about the importance of the gluteal muscles controlling the hip joint. And so what I have found, Mike, is that when the butt muscles, that our hip joint is stabilized from the outside by the butt muscles. It's stabilized from the inside by the groin muscles. If you look at the architecture of the groin muscles, they're huge, and they all run on the inside of the leg like this. And so they are affecting the hip joint from the inside, while the butt muscles are affecting the hip joint from the outside. What I have found is that the less the butt muscles are working to control the hip joint, the more the inner thigh muscles are working to control the hip joint. And so we tend to get spasm in the adductors. So what I would say is, again, try the butt pump exercise that we talked about at the beginning of the session to start activating your butt and start your walking and changing your walking pattern to turn on your butt pump. How do we do that? Well, we mentioned that again, that your body needs to come forward with the advancing foot rather than the foot coming forward without your body. This will allow the knee to be bent and your body to be over the foot at foot strike, which will naturally turn on your butt. The more this happens, the less the adductors will have to control that hip joint. So that's one big picture idea. The other is that, and I mentioned this anterior femoral glide syndrome before, if the butt muscle isn't working well, and I would almost guarantee that it's not in this case, and the thigh bone is migrating forward in the hip socket, what happens is you can get labral tears and pinching of the psoas and groin tissue pinching from the femur head that's migrating forward and pinching it. How do we solve that? Well, again, do the butt pump exercise and start walking correctly to suck that femur head back in the hip socket the way it's supposed to be, and it will unload these groin tissues and solve likely that groin pain too.
Kind of an interesting question. This is from Patty. Son has pain after cut injury to the back of his heel near Achilles, then had stitches a year ago. When wearing shoes, he is in a lot of pain, can do anything barefooted. How can he be pain-free? It sounds to me like he has some type of sensitivity in the area if something's rubbing on it. So that's why he's probably feeling good barefooted. The only other thing I'm thinking of is a lot of shoes have elevated heels compared to forefoot. When you're barefoot, you don't have that, obviously. Your front of your foot is the same height off the ground as your heel. So you can look into footwear that's called zero drop. They make some that's very skinny and some has more cushioning. Obviously, if it's still frictioning on his heel, though, it could bother him. So I guess just look in the footwear that he finds comfortable. There's tons of brands of zero drop. I'm assuming your son is probably finding like flip-flops because there's nothing on the heel. But it might just be getting his heel acclimated to having kind of something there, or he might have some scar tissue in there from the stitches. So maybe doing some scar tissue release on the Achilles tendon could be beneficial too. Do you have anything to add?
Yeah, I think you're right on, Mike. I don't have much to add, but I would consider some desensitization techniques And when he's not in shoes, for him just to rub that scar to see if he can cause it to become desensitized. Even massage out if there are nerves kind of bundled up in there, kind of willy-nilly because of the scar tissue, rubbing that scar along the, vertically can help reorient those nerves to be running the way they're supposed to and desensitize that nerve irritation. So even if it was a year ago, I think it's worth a try for the next, say, 2 weeks and see if he spends a lot of time during the day just massaging that in an up and down way along the grain of the Achilles tendon. Let's see if that solves the problem. And then the other thing would be, I'm sure that they've tried this, is putting gauze pads over, maybe getting an oversized shoe, putting a gauze pad over that really sensitive area. And so that would decrease the rubbing on that. And then I wonder if he can become desensitized like that. And so what you would gradually do is reduce the padding required on the heel as he feels better, and then reduce the shoe size again back to the normal shoe. So I agree with you that this sounds like a sensitization issue, not a biomechanical function issue. And that's how I would kind of think about it.
Yeah, I mean, you can ask him or make sure his range of motion looks similar between both ankles, but I'm assuming if he's barefoot, it's probably fine.
Yeah, if you can walk barefoot,
and that's when it feels good.
Yeah, exactly. There's a couple of easy tests, testing your calf and testing your soleus muscle. I have that on my YouTube channel too, that you can assess those to see if he has some biomechanical deficits in the foot ankle region that could be contributing to excessive stress to the Achilles tendon and therefore irritating this as well. So
here's a good question. So Kathleen says, for elders who cannot get down on all fours, like the stretch you're talking about, what's a good way they can do it in a chair? I'm sitting in a chair. So you can do it standing too if you really want. You just have to put your hands on a countertop. So if you're in a chair, just put your hands on something, and then I have a rolling chair so I can roll back and do it this way. If you're at a kitchen table, you would just, if your table's doesn't slide well, you can just put a towel down and then slide forward as far as you can and do it in a seated position if you don't like getting on your hands and knees. If you're at a countertop, you can just walk away backwards while keeping your hands on the counter there. So those are some options to do it.
And then another one is, I'm going to turn my camera here. So you can see me okay here. If we pretend like this is a door and I've opened it and now I'm holding on to both handles on either side of the door, you can hold on to those and then lean back and stretch like that. So you can do it standing as well that way. And for instance, here's what it would look like. I've got my little machine back here. If I hold on to that and I just lean back like this, that's doing the same thing. So you don't have to be on your hands and knees on the floor.
We've had a couple questions kind of on the same thing about earlier. We talked about walking properly. Could you demonstrate proper form for walking without locking knees? Because I think some of them missed it or were curious more. So do you want to go over that quick?
Yeah, this will expose that I'm here in my shorts and bare feet.
I'm in flip-flops and shorts, so not too far
okay. Okay, so, all right, let's see. Good. So the way that most people walk is that the heel is advancing and then in front of you, and then when this happens, the knee straightens. And once the knee straightens, it turns off all of this musculature. So then we go over our body like this. So here is incorrect walking, foot out in front, body is behind, right? And we do this because usually of thick heels on our shoes that allow us to strike hard on the heel, which then automatically locks the knee, turning off this musculature. So the way it should happen is that the body should be advancing with the advancing foot, like this, all right? And this will feel very awkward for most of you. So you can even start with little teeny tiny steps teaching your body to advance with the foot. And I mean, normal walking from, this is normal walking and my body is advancing with the foot. So it doesn't, while it's going to feel weird to you, it doesn't look weird once you get this. So that's basically how you train this. So a trick that I use for a lot of my patients is I have them do tiptoe walking. So if you get up on your tippy toes and you walk around, it's impossible for your foot to land in front of you and walk forward with tiptoe walking. So your body is forced to align over the foot when you're walking on your tiptoes. And your knees are therefore also bent. And so tiptoe walking is an easy way to not even think about it. That will turn on the butt, align your body over your foot, and then what you can do is just gradually lower your heels down, and you'll find that you maintain that tiptoe walking, those mechanics, even with your heels down temporarily. And so what I often have people do is every time they stand up from a chair or bed or whatever, the first 5 to 10 steps should be tiptoe walking to train their body to kick into that proper walking mechanics. And then they can lower the heels back down and walk normally again. If you're walking around the block, then, tiptoe walk for 20 steps and then bring the heels down. And what I have my patients do to make sure that they're doing it right is I have them put their hands on their butt muscles, because this is the whole purpose of doing this, is to have the butt firing. And when you're tiptoe walking, you should feel that the butt muscles are turning on like 5 or 10% of their maximal contraction. And then once you lower your heels, they stay turned on if you're walking correctly. That's how you can test out in the wild whether your butt is working correctly.
We're kind of running out of time now. Do you want to take one more question?
Sure.
There's quite a few here. I'll just go with this one. So Jill says shoulder replacement and then reverse shoulder replacement. It's been 2 years. I still can't raise my arm enough to be useful. Unfortunately, sometimes with the reverse shoulder, oftentimes they try to go around your rotator cuff for whatever reason, which is part of what helps you lift your arm up high enough. And it's usually a doctor's way of you're having a lot of pain, but maybe you're not a great candidate for rotator cuff repair. So that's kind of what they do to get you out of pain. Some people, if they have good motion before, they can kind of maintain it. But I've worked with a handful of reverse shoulders that are kind of in the same boat where like they can only lift it about this high to a point, and that's about all they really get back. Just because it's been years since they've been able to get up. And then, but when I asked them, like, are you still having pain? And they're like, well, no, it doesn't hurt anymore, because they were in extreme pain. So that's kind of my experience working with them, but not saying that you can't still work on your range of motion and stretching. It's still a good idea, but I can't guarantee stuff's going to come back. I don't know if you have more to add.
Well, again, I would wonder what your shoulder blade is doing to help your shoulder get overhead, because even with a reverse shoulder replacement, so they do a reverse shoulder replacement when they feel the primary rotator cuff muscle needs to be abandoned because of tearing, tissue integrity, or whatever. So then the deltoid muscles become the rotator cuff for you. So and so even with that, the scapula still needs to move in order to help that arm get overhead. So what I would be curious about, Mike, is, for instance, can she reach up this high? My elbow is still below shoulder height, and then can she lower her body down away from the arm and get the arm up above the head like this? So that would be something I would experiment with to see whether, what if you pulled the arm up, can it physically go above your head? And if so, is it just a strength issue? So if it can physically go above your head, then, do what I just did, lower yourself down, have your arm go above your head, and then walk away from that and see how long you can hold it up there. That is strength training. And then you would slowly try to lower it down, use your other hand if need be to help you, or use your other hand to help it go up. So I'm not clear whether she has a mechanical block in terms of her range of motion, or whether this is just a strength issue that she hasn't been trained to overcome yet. So if it's a strength issue, that's how I would do it is, even though all fours rocking stretch can help get that arm up overhead and stretch the tissues that are preventing the arm from going up overhead. The more that they are stretched, the less strength you need to push against them to get your arm up overhead. So what if this was just a tight depressor problem that's pulling the arm down and your deltoids are just not strong enough to fight against that, especially if the scapula isn't helping either. So there's a lot of questions about that type of scenario. I would not give up. There's just too many things to explore here.
Yeah, the person I worked with that had this, that was kind of in the same boat, was she could do like the all fours, like holding onto the door frame and going back well. And then she could really do tabletop slides well too. Those are the main ones. Like, obviously we have like pulleys and other stuff in therapy gyms, but those two are the main ones that really helped with her. She is still watching, Jill. She just said she can't reach that high. So yeah, I would just say start with the lower surface and then just try to go back, because that's going to do the same kind of concept what I'm doing right now.
Yeah, I agree with you, Mike. And I had shoulder surgery last year, and this is also something I use with my patients is you may not be able to reach that high, but that doesn't mean that your shoulder can't move that high. And what Mike's trying to describe is that if you can pull your shoulder up higher, even though you can't reach that high, you can pull your arm up higher. And if you can pull your arm up higher, then you potentially can then learn to reach that high.
She can lift it up with her other hand, so she
There
does
we go.
have a motion.
So she has the range of motion. She just needs to work in that higher range of motion now. And so I would do that, like if you go up against a wall, let's see, get my skeleton out of the way. Okay, so here's, can you hear me okay, Mike?
Yeah.
Okay, so if we just slide up against the wall, and let's say she can't get above here on her own, well, okay, use your other arm to help you. Get as high as you possibly can. And then try to hold it up there and see if you can come away from that wall holding it up there. And if you can't, use this hand as much as necessary to help it stay up there until you need to bring it down. If it's too painful to bring it down without the wall, then go back to the wall and slide it back down again. But that's how I would start training this, is getting it in the range of motion that you're having trouble with and trying to strengthen that zone, that arc of motion, to see if we can get some strength there and function. Largely, I'm going to bet this has something to do with the shoulder blade. So we need to get that shoulder blade moving for her.
Yeah, some people, if they really struggle just with wall slides, I've even used like the big yoga ball behind you.
Absolutely.
And rolled that up the wall just because it kind of helps some people with that big surface.
Yep.
So
absolutely.
But you don't need to buy it, Jill, if you don't have one available. But all right, well, there's still a lot of questions, but we've ran an hour, and we'll be back. Well, Brad and I will be back next week with the live. Rick will join me again next month sometime. We'll have to figure out a date yet, but I know you're going on an expedition.
Yeah. So I don't know how you feel about this, Mike, but if you want to submit those questions to me, I can answer them. I'll make a video on my YouTube channel or something like that to answer as many as I can. Unless you and Brad are going to answer them next time.
No. We kind of pick a subject and stick with it. We don't go all over the place.
Okay.
So I will, I can copy them and send them to you. They're all from YouTube. The only problem is, for some reason, when we're live on YouTube, they disappear after, but I can copy them from StreamYard here and send them to you.
Yeah, just send me the questions. I'll make a video and answer as many as I can. That way I can organize them, and I can answer bunches of them probably at once.
Sure.
Go a little deeper.
Yeah, there's a handful of similar. Some of them are like so specific, it's kind of hard. But so if you want to check out,
I hate for people not to get the answers that they're looking for. There's so many people out there.
Yeah. If you want to check out Rick, you can go to rickolderman.com and all his stuff can be found there. And he also has a YouTube channel as well. Just search Rick Olderman on YouTube and he should come up. I think we linked it in our meeting. Yeah, it's just youtube.com/Rick Olderman PT is your YouTube channel. So, all right. Is there anything else I forgot or you'd like to mention? Oh, you do have.
I just want to mention, folks, that a lot of, especially for the low back, hip, lower body questions, I have a new book out called Pain Patterns. It's on Amazon. It just won a national award too. And a lot of my whole philosophy about, if all of this sounds really weird to you and different, then I think you should read that book, because I think you'll understand exactly, you'll learn so much about your body. But the second half of the book functions as a workbook that you can test your body and see where your deficits are. And then I tell you how that's playing into your pain. And all of the tests and exercises can be found as videos on my website. But I would really encourage people to get the Pain Patterns book, because it will explain a whole new way of understanding the body, which is what Mike and I have been talking about this past hour. And I think it will really help a lot of these people. It has only one of the tests involve the upper body for the head, neck, chronic pain, but all the other tests, and there are only like 6. It's not like a tome, but there are like 6 tests in there to help you understand the big reasons why you're still struggling with pain that most practitioners aren't thinking about for you, and how to link those problems to your current pain.
Well, thank you everyone for joining us. We'll be back next week at 10 a.m. Central Time, and we will see you then.